Okay. Okay. Hello, everybody. Good afternoon. I'm Dr. Riva. Today, we will be talking about our third lecture on the cardiology section. And by this time, we have gone through the basic physiology and the anatomy related to the cardiovascular system, as well as in the first lecture, we have discussed about the valvular heart disease and the congenital heart disease. We have discussed about the different types of cardiac investigations. And in the second lecture, we have discussed about the, primarily we have discussed about the cardiac arrhythmia, which I used to find very complex back in my MRCP Part 1 preparation, which is why I actually decided to, solely contribute one entire class for the purpose of the cardiac arrhythmia. And I had a bit of a question answer session at the end of my lecture. And in my third lecture today, we will be going through different types of rather common cardiology topics. For example, ischemic heart disease. At the same time, we will discuss about heart failure, cardiac myopathies, and a very preliminary idea about the hypertension management. Okay, I think I'll start. So, before I start our today's conversation, I can appreciate that there are two candidates in front of me. I hope that you guys went through the summary of the cardiac arrhythmia back in home. And if you have any question for me or anyone from the online, I can appreciate there are one participant right now, two participants right now, Dr. Anupam Biswas and Dr. Neha Singh. If you have any question for me from cardiac arrhythmia or the first lecture, you can ask me right away. Okay, you can also write to me in the chat box. And today I will start with the first topic, which is very important topic, not just from a MRCP point of view, but at the same time, it's very important topic from the perspective of real life implication as well. So coronary artery disease, or ischemic heart disease, is our first topic today. So the term ischemic heart disease is very much implicable for there is some sort of ischemia or reduction in the blood flow occurring. So what does ischemic heart disease mean? It means that when there is some sort of interruption in the blood flow of the coronary circulation. And from our very preliminary undergrad level, we have been emphasizing on this very much, because this is actually one of the most commonest and one of the most important medical emergency situation. So the term ischemic heart disease is now broadly classified into two groups. One is the acute coronary syndrome and the other one is the chronic coronary syndrome. Previously, I know that we have in the Davidson, we have read about the stable angina, unstable angina, and myocardial ischemia. The classification is nowadays a bit different, okay? So it has been broadly classified into two groups, acute and chronic coronary syndrome. And the term acute coronary syndrome is further divided into three groups. One is unstable angina, and the other one is the ST elevated MI, and the other one is the non-ST elevated MI, okay? So this is actually today's conversation I've tried to incorporate from three guidelines so far. One, the European Cardiac Society, and the other one is the American Heart Association and New York Heart Association, and also the NHA's guideline, which goes by the NICE guideline, okay? So I've tried to incorporate all of these and then summarized into a very gist form, which will actually help you to go through the given topic in your books or the lecture notes, okay? So the term unstable angina, we'll discuss about this a bit later on. And previously, what was known as the stable angina has been now broadly given into the chronic coronary syndrome, or after the acute coronary syndrome, this the acute emergency has subsided. Now the patient is on either maximum guideline directed medical therapy, or maybe the person has undergone some sort of angioplasty, or maybe CABG, some sort of intervention, but still has some sort of anginal chest pain, which is typical of anginal chest pain, but it is not as severe as unstable angina, and it does not have any severe risk factor into developing acute coronary syndrome. So any anginal chest pain that is relatively stable, this is broadly within into the chronic coronary syndrome category. This does not actually follow the particular time frame. Like we know in our medical knowledge that whenever some symptom persists less than 6 months and more than 6 months, that is known as acute versus coronary. But this this arbitrary timeline has been withdrawn these days. Okay, so we will discuss about what exactly is a typical anginal chest pain looks like or feels like. Chest pain. Okay, when is it important? When is it important? And by that, I mean, when would you think that this is a kind of anginal chest pain? Okay. So first of all, if we divide it into the Socrates formula, then the site is central, onset is sudden, character is, could be various form actually, could be dull, constricting, squeezing, or some sort of chest discomfort. Most of the time, how many of you, I'm not sure how many of you have faced this type of emergency situation back in your hospital, but can you name me a few of the words or the local words that the patient usually tell when they have the typical chest pain? What's the terminology? Do they tell you that? Exactly. So constricting is a commonly phrased word, as well as the most common terminology that I have been associated with is that I don't feel so good. That's actually the one of the most common thing. They cannot really tell you how exactly, but they say like something is about to happen. I can feel it. I feel I'm sweating. I feel like throwing up, but I haven't thrown up, and I don't feel good. I feel restless. These are the common manifestation of a coronary heart disease or ischemic heart disease. Okay. And then the radiation, not all the time I would say that presents with radiation, but we should be aware like where exactly the chest pain radiates. So it can radiate to the jaw area, it can radiate to the left arm, it can radiate to the back, also it can radiate to the shoulder region. Okay, so these are the sites of radiation: jaw, left arm, etc. And then what are the did I misspell Socrates? No, that's fine. So the aggravating and the relieving factor. Aggravating factor is mostly, it is increased by doing some sort of activity, maybe exertion, exercise, and then cold weather, or maybe you're walking up a, like inclined position. So inclination is one of the important aggravating factors. And the relieving factors are typically when there is unstable angina, it does not relieve by any rest or any GTN spray. But in a anginal chest pain, especially the stable anginal chest pain, it usually relieves by taking rest or taking a GTN spray. Okay. Okay, and then the timing, that is also important. Timing is sometimes it can be associated, just like I said, that it is associated with whenever you're exerting yourself, whenever you're having some sort of meal. Even taking meal can actually precipitate the MI attack. Like if you're under any anxious, like stress situation, then it can provoke it. Another timing is it does not follow any particular diurnal variation. Rather, I would say maybe related to activity or meal. Okay. All right, and what is the E? I think E is, wasn't it associating factor? Socrates? It was associating factor, right? So what does the E mean? I forgot. Okay, let's just think this is an associating factor. Association. So it is usually associated with nausea, vomiting, restlessness, and profuse sweating. And sometimes it can present with cardiac symptom like dizziness, loss of consciousness, or even shortness of breath. Okay, so these are the associating factors of a typical anginal chest pain. So I'll try to summarize: sudden, severe central chest pain which radiates to the jaw or the left arm or the shoulder, maybe sometimes radiating towards the back as well. It can be dull, aching, constricting, squeezing, chest discomfort, and it is usually increased by taking meal, doing some exercise or activity, and it can increase by stress, anxiety, exposure to the cold weather, and it's relieved by taking rest or GTN spray. And it does not have any particular diurnal variation, rather it follows some sort of exercise or activity or meal. And associating factor would be feeling nausea, vomiting, restlessness, sweating. Sometimes even they can present with shortness of breath, feature of syncope or syncopal attack. So this is how a typical chest pain looks like. From the audience side, someone is unmuted. It would be really best if you can mute yourself. Dr. Kamal. I'm sorry I have to mute you, but I will, later on I will unmute all of you guys. Okay, so, all right, sorry about that. Okay. What is that? It's actually coming from my side, right? Okay. Okay, sorry about that for the noise interruption. Anyway, so what are the examination finding or on examination, clinical examination finding? Okay. Most of the time, this can be very normal. That is the normal finding. Like you wouldn't really get any abnormality if you examine the pulse, JVP, blood pressure, or the precordium. But I'll tell you about some of the abnormalities that might present. Okay. For example, if you start off with pulse, so first of all, ABC protocol is very important because it is an emergency. So you should see whether the patient is first of all conscious or not. Then you should see whether the airway is patent or not. Then you should see whether the patient is GCS scoring. That is also important. That is actually to evaluate the consciousness level. And the patient's position, whether the patient is sitting up, gasping for air, or whether the patient is feeling any restless. Like examining the patient's outward appearance is very important. Okay, now coming back to the examination, pulse. This is very important to check pulse and blood pressure, because this way we will say whether the patient is having any cardiogenic shock or not. So it usually signifies whether a patient is stable versus unstable. Okay, so pulse can be tachy or Brady, because particularly more importantly, inferior MI. Okay, and it can be normal as well. And now in terms of blood pressure can be, it can be normal. Most of the time it is normal. And sometimes because of the low perfusion, the diastolic filling pressure can be reduced. So the diastolic blood pressure can be reduced, okay? And if there is background of hypertension, then, like you'll get the hypertensive changes, like hypertensive features. And okay, from the pulse, JVP is usually normal, not raised. That means not raised. However, if there is systemic congestion or features of right heart failure, which is a rather bit unusual for acute coronary syndrome, because it usually takes like several months to years to develop the systemic congestion, okay? It's more common that you might expect features of pulmonary congestion in the background of ischemic heart disease earlier because of the left heart failure. So JVP will be raised if there is some sort of cardiac event that has occurred before, and now the patient has presented with another type of MI, another attack of MI, and now he has, during that particular time, he has developed features of systemic congestion, thereby causing raised JVP. So that's a plausible explanation, okay? And then moving on, you should look for the facial features. Facial features as in like whether the patient is sweating, irritable, anxious look, the patient might be gasping for air, there might be anemia is not really like a feature of acute MI, but if a patient is having long-standing heart failure, on the background, you see the patient is having another attack of MI, then that can be, like the patient might be having anemia. Okay, and now for the facial feature, you should definitely check for the neck to see if there is any goiter. Because why goiter? Because thyrotoxicosis can actually mimic or precipitate the anginal events or MI. So that's why goiter assessment is quite important. And then in the precordium, let's go to the precordium. So the precordium is usually normal. In the event of inferior MI, sometimes, or cardiogenic shock, sometimes it can mimic silent chest, okay? Because the cardiac output has been severely reduced. So sometimes you would not be able to get the first or second heart sound to tell it differently. In fact, now that we are preparing for PACES and all the precordial cases that we go through, like in order to detect the murmur and everything, I have seen that people who are having maybe triple vessel disease or something like that, if you auscultate their chest versus a normal healthy individual chest, the heart sounds are very poor and the heart sounds are very inaudible in triple vessel disease, okay, because of the low perfusion. And another thing you can expect is a pansystolic murmur of the mitral regurgitation, which occurs due to, this is actually a functional MR. Functional MR can occur either in two forms. I'll tell you why, because this is important. If you're getting acute MR, this is highly severe, it's medical emergency, needs urgent surgical repair. Why exactly? Because if you see on the background of MI, if the mitral regurgitation happens, if the functional mitral regurgitation takes place on an acute event, then it signifies that there has been rupture of the chordae tendineae or the papillary muscle, which has caused the mitral regurgitation. And the mortality rate is more than 80 to 90% in these kind of patients. But in long-standing ischemic heart disease, there is usually within the left heart, there is more hyperdynamic circulation, more of the blood volume, or the pressure effect is causing dilatation of the mitral mitral annulus, okay? So because of the pressure effect as well as the volume effect, it can be dilated, thereby causing a functional mitral regurgitation. But this is not a medical emergency. So I hope you guys are clear. Okay. On the lung bases are important to auscultate, back to the examination part, because if in case of acute left ventricular failure, which can be a common association with acute MI, if the patient presents with that acute left ventricular failure, you might expect fine to coarse bibasal crepitation, which does not alter after cuffing. So this is actually an important finding. So you should be very much, aware of this finding. Next is abdomen examination is not that important unless there is congestive cardiac failure, which is not a feature of acute MI. You might expect the tender hepatomegaly or ascites or features of systemic congestion might be present. And legs are, well, plus minus edema. So I would again say that features of pulmonary congestion or systemic congestion, these are all complicated scenarios with MI, complication, okay? In normal acute MI, expected findings are normal. This is the most common finding for MI patients. But if it is complicated and presents with left heart failure, then you'll get features of pulmonary congestion. If it is presented with right heart failure for a long-standing time, you might get features of systemic congestion, okay? All right. So let's go to the investigation. What are the investigations for MI patients? So while you are assessing for the patient, take a short history of the chest pain and taking, like whether the patient has any risk factor. You have very limited time here. So you should be taking the history of chest pain, assess whether the patient is hemodynamically stable or unstable, whether the patient has any other comorbidities, like whether the patient has diabetes, hypertension, chronic kidney disease, any thyroid problem. And then you should ask about the family history, whether the patient has any family history of sudden cardiac death. And also apart from that, family history is pretty important because we know that heart diseases are more common and it has genetic predisposition, right? So, and also at the same time, you should inquire about whether the patient is a smoker or not. These are the very important parts in the history for an MI patient. And next investigation is while you're checking the patient's pulse and blood pressure, you should do a 12-lead ECG right away. There should not be any delay whatsoever. In hyperacute MI, usually ECG changes are very non-specific, but there is one very important finding seen in the hyperacute stage, and that is the tall symmetrical T wave. So both the limbs of the T wave would be very tall, like this, okay? And this limb will be equal to this, the other limb of the T wave. So this is a characteristic feature for hyperacute MI. I'm not saying that you cannot get tall T in any other pathology. You can, like for example, in hyperkalemia, we can expect the tall T to happen as well. But in the background of a chest pain, if you are having no features of ST elevation or no features of ST depression, you're not getting any T wave inversion, rather you're getting tall T wave changes, then you should be very prompt towards investigating for whether this is a case of MI or not. And you should give the cardiac enzymes, troponin I and CKMB right away, okay? All right, so the next best investigation is to do some blood tests you need to do. Like for example, if we start with the basic investigation, like in CBC with ESR and CRP, the inflammatory markers can be raised in the acute event. And CBC, we would be expecting the WBC count can be raised, okay? There might be neutrophilia, but this is aseptic neutrophilia. And then next one should be, we should go for the cardiac enzyme marker like troponin I, CKMB. In UK, they go for the myoglobin level because cardiac myoglobins are the first one to rise even before the tropi levels. And if it's a reinfarction, then rather than going for the tropi again, we should go for the emphasize on the CKMB, okay? Because tropi disappears, tropi when it is raised, it stays longer time in the circulation. So it's very difficult to comment whether the patient is having reinfarction or not. So the CKMB actually disappears on a, like a shorter time. So that's why you should go for the CKMB for assessment of reinfarction. Okay, after the cardiac enzyme, we should go for risk stratification, like RBS or FBS if the patient is having diabetes, HbA1c can be given. And then definitely serum urea and electrolyte, because the electrolyte imbalance will further provoke the myocardial infarction. At the same time, you should be, like modification of a few other drugs. You should consider doing the baseline serum electrolyte. And then serum creatinine, because heart and kidney, these are, like very much intertwined. When the heart stops working, the kidney will stop working. And when the kidney stops working, the heart will stop working. So when there is cardiac hyperperfusion, there will be kidney hyperperfusion. And this is actually another emergency. So you should definitely check the creatinine level on a regular basis. Serum creatinine or urine analysis, these are important. Urine analysis. In a lot of the tertiary centers, they go for the SGPT level as well. And that is also because we are supposed to give the statin in these persons, right? Because statin will also have some anti-ischemic property as well, and it has a very good cardiac mortality rate, okay? It prevents further cardiac mortality or morbidity, reduces the overall burden. So that's why SGPT level should be done. This is just the very basic investigations you should do. And if you get time, once you're starting the treatment, you should arrange for an echocardiography. Echo, the striking echo finding, what is that? It is regional wall motion abnormality, RWMA. For example, the patient has had inferior MI. So the inferior wall will be having it's very territorial, okay? So a particular territory where exactly the infarction has taken place in the echocardiography, you might get hypokinesia or free wall movement. I will not really go into the details of the echocardiographic finding. I will just tell you like very basic or just findings for the MI, free wall movement. So these are the echocardiographic features. And in the acute event, the left ventricular ejection fraction is not reduced, but over a long period and when the heart output reduces, then you might expect the LVEF to be less than 50%, okay? Especially, this is particularly important in determining heart failure. Okay, and after the echocardiographic finding, now let's talk about the management, okay? which is actually, I know we all have been waiting for so far, management of the acute MI. So management strategy is a bit different from the ST elevated MI versus non-ST elevated MI, okay? So ST elevated MI basically means that the myocardial injury or the myocardial ischemia has been transmural, okay? So that means that the myocardium, like say for example, this particular segment has been, hypoperfusion is going on and the artery here is occluded. And then the entire myocardium here, this has been non-salvageable or there is myocardial necrosis, okay? So it is involving the entire circumference of the myocardium. This is known as the ST elevated MI. And the non-ST elevated MI is actually subendocardial, could be subendocardial or a fraction of the myocardium has been affected. Okay, so that is non-ST elevated MI. So non-ST elevated MI never go for any thrombolytics. I will just talk about the basic difference between the management of the ST and the non-ST elevated MI. So do not go for the thrombolytics because it will cause reperfusion injury here. All right. And in case of a PCI or the primary coronary intervention, ST elevated MI door to needle time is 2 hours. That is ideal. But what if you cannot do the coronary intervention or the stenting within a very short period of time? You should consider the primary PCI strategy. Primary PCI strategy. And this should be done within 12 hours. If you cannot do this within 12 hours, then your next target should be 24 hours or as soon as possible. That becomes quite arbitrary and depends on the cardiologist and other facility availability and blah, blah, blah. But the main thing you should remember is that the door to needle time is ideally 2 hours in case of an acute ST elevated MI. And if you cannot go for that, go for the primary PCI strategy, which is to do the intervention within 12 hours. And in case of a non-ST elevated MI, we do have some time. So we should opt for, maximum pharmacological therapy, as well as you should not opt for any thrombolytics here. Rather, you can go for like maybe low molecular weight heparin or fondaparinux, which is like an antithrombin. So you can go for that. And if we can go for a bit longer time period for the angiogram to be done. So it can be within 24 to 96 hours from the first hospital admission. So this is just the very basic difference between the ST and the non-ST elevated MI. Now, I will start with what are before I tell you what exactly should be done in an acute event, I will discuss about the pharmacological management a bit broadly, like talk about the drugs in general, then I will discuss about what you should do in terms of an acute emergency or acute coronary syndrome. So first, what are the drugs? Okay, so Dr. Deep. Okay, so what's the first and foremost important drug that you should give to a patient with acute coronary syndrome?
Aspirin.
Aspirin. And tell me the loading dose?
325 milligram.
300 milligram.
Oh, okay.
Aspirin is 300 milligram. Okay. And along with that, are you going for the single antiplatelet strategy or dual antiplatelet strategy?
I think the new guidelines suppose
dual antiplatelet strategy, exactly. Aspirin plus clopidogrel, both 300 plus 300, total 600 milligram bolus dose, okay? All right, so can you tell me an alternative to clopidogrel? Ticagrelor, very good. And what's the loading dose of ticagrelor? Yes, it's 90 plus 90, that is 180 milligram. So ticagrelor is actually another type of ADP receptor inhibitor, same mechanism as the clopidogrel. But in patients who are unsuitable match for clopidogrel, maybe the patient is already taking high doses of PPI, then we know that PPI actually, inhibits the properties of the clopidogrel. So we can go for another alternative medication like ticagrelor. So anyway, first of all, our first drug is the antiplatelet. Okay, very important. Antiplatelet in the form of combination or dual antiplatelet therapy or the DAP therapy. Aspirin plus clopidogrel. So that is 300, and clopidogrel is 300 milligram bolus. Okay, number 2 important medication that should be given is the patient is having patient is having chest pain. Patient's cardiac demand has increased, but the supply has been reduced, and we need to stop that from happening. Okay, so what type of medication we should go for? Something that will cause venodilatation, thereby reducing the myocardial oxygen demand, and that is GTN. Okay, so in the Western world, they go for the intravenous GTN because whenever you're prescribing with GTN, it can cause systemic hypoperfusion. So they have very higher facilities. They can do a CV line right away. They can measure the central venous pressure and thereby adjust, like according to that, they can adjust their doses. But in our country, we do not really have that facility going on. So instead of going for the intravenous GTN, we do not like to take risk because hypoperfusion can actually potentiate your risk of myocardial injury. So we should go for something a bit milder, at the same time, something that protects your heart on a longer period of time. So we go for the like GT isosorbate mononitrate sustained release. Okay, like in our country, this is most commonly practiced is maybe tablet Nidocard or maybe tablet GTN 2.6 milligram sustained release. And there are some ways you should consider giving the GTN. First of all, you need to check the blood pressure on regular intervals, maybe 30 minutes and then 1 hour to 2 hours, something like that. You do not want the hypoperfusion because it can reduce the BP, okay? And at the same time, you should consider giving the medication one dose at the 8 a.m. in the morning, and then the next dose at 4 p.m. And in between the 2 doses, you should have 8-hour time difference rather than 12-hour time difference, okay? Because if you're giving 12-hour time difference, then there is chance of GTN tolerance. All right, and another medication that is that should be given in order to reduce the ongoing chest pain, and that is IV morphine. And we know that morphine can induce vomiting tendency. So along with the morphine, we give the injectable antiemetics. In our country, we do have, we don't really like to go for the morphine, rather because it can cause the cardiorespiratory depression. So instead of giving morphine, we go for the pethidine injection. Okay, and along with the antiemetic, maybe injectable Vargon or maybe injectable Emistat, medications like that. Okay, okay, number 4, this is also very important, and that is statins. Statins are very important. High dose statins. In America, Northern Europe, and in UK countries or Canadian population, their body is a bit different built compared to our body. So they go for the highest dose possible. So their highest dose is 80 milligram, okay? And studies have shown that atorvastatins, these are superior to rosuvastatin. However, atorvastatin has its own complication. Profile is a bit more higher, like for example, myopathies or myositis, and increase in the liver enzymes. These are more common in atorvastatin. But in case of a cardiac event, they have done several trials where the atorvastatin have been proven to be superior to the rosuvastatin. Okay, so the initial dose is 80 milligram. In our country, we go for 40 milligram. Half the dose, okay, because our body cannot tolerate that high doses of lipid lowering agents. Okay, number 5 drug, that is beta blocker. Very, very important. Previously, it was said that in the acute event, like especially in decompensated heart failure, acute heart failure, beta blocker should not be given. But now this, idea has been revolutionarily changed, because beta blocker not only reduces the myocardial oxygen demand, but at the same time, it prevents cardiac remodeling. Okay, so it has been proven to show mortality benefits. So you should, now the studies are saying that you should start the beta blocker as soon as possible once the MI or any cardiac event has taken place. So beta blocker, which beta blocker is particularly important? If carvedilol, bisoprolol, and nebivolol. In NHS, they usually go for the nebivolol very much. In our country, we go for the bisoprolol or the metoprolol, or even carvedilol, the non-selective beta blockers. Okay, the next one is calcium channel blocker. That is, if some people are not gonna get beta blocker, for example, patient is having severe asthma or COPD, then you can go for the calcium channel blocker. In that case, which calcium channel blockers are particularly preferred? The rate limiting ones, okay? So like verapamil or diltiazem, Vera or diltiazem is superior to the dihydropyridine groups. And by dihydropyridine, I mean maybe nifedipine, those medication, okay? But then again, you should be very much cautious, like never give beta blocker along with the rate limiting calcium channel blocker. This combination is a no, okay? It will cause severe myocardial depression. All right, number 7 is that ACE inhibitor. Okay, so ACE inhibitor, we can go for the, like we practice a lot of telmisartans these days. But before that, always classic is the better. So ramipril, tablet ramipril, we should start off with lowest dose possible because it can cause increase in it can cause hyperkalemia, okay? So that's why we should start with maybe 1.25 to 2.5 milligram initially, and then, like titrate the dose upwards. And ACE inhibitor has also been shown to, like improve the mortality associated with the cardiac events. So it has mortality benefit as well. And start with the lowest dose possible. This also prevents the cardiac remodeling. All right, so ACE inhibitor, and the next drugs are the other medication, all the other, you can just remember it like others. By others, I mean medications like ivabradine. Ivabradine is like it's a funny channel inhibitor. So it inhibits the sodium channels located in the SA node. And it has some anti-ischemic properties as well. And there is another medication these days, they're using it a lot, that is potassium channel activator. And within this tablet, ranolazine, or another one is, I think, nicorandil. These are anti-ischemic properties, okay? All right, so far, any one of you have questions for me? Okay. Dr. Neha Singh, are you there?
Yes, ma'am.
Okay. So do you have any questions for me at this stage?
No, ma'am.
Okay. In
I have a
India.
question.
Okay, yes, sure, go on.
Low molecular weight heparin, it is used or not?
Yes, it is used. I will actually talk about this in a bit later on, okay? I will give your answer a bit later on. Okay, so in India, Dr. Neha, which do you think the medication strategy or the protocol is very much similar to our country?
Yes, ma'am. Quite very similar.
Okay. Do you guys go for the intravenous GTN?
Yes, ma'am. Depends upon the case. We actually start with like any anticoagulants. We also had Lasix with the patient, like to the medications mostly, and any antihypertensives actually.
Okay, okay.
Lasix, anticoagulant, and antihypertensive. These are the three medicines.
Anticoagulants or antiplatelets, do you mean? Antiplatelets, right?
Yeah, anticoagulants as well.
Anticoagulants, that is actually not really preferred because it can cause more harm than benefit. But nowadays, this has been established that the low molecular weight heparin can be given, okay? But
Low
not the
molecular weight
other ones.
heparin. Yeah, not anticoagulants exactly. I'm talking about the heparin only.
Yes,
Yeah.
okay, got it. All right. Okay. So as Dr. Kamal raised this issue, yes, we do give low molecular weight heparin, but according to the NICE guideline, they're saying that this is particularly important for the non-ST elevated MI, because you're already giving optimum dose coverage for a patient with ST elevated MI, and you're planning to go for the ultimate event, which is the PCI, okay? So if you're aiming for the PCI within 2 hours, or if you have already given the patient thrombolytics and you're awaiting for PCI to take place within the next 12 hours, then there is no need to go for further anticoagulation. That will actually cause more bleeding risk in that patient, okay? So basically, like think as a rational person. So if you're aiming for an intervention, coronary intervention within a short period of time, then you're already giving the patient antiplatelets, okay? Like in the form of dual antiplatelets, bolus doses, and then you're going to be maintaining that with the dual antiplatelets as well. So if you're aiming for that, for the coronary intervention to take place within a short time, you don't want to take chances for bleeding risk, okay? So you don't have to really go for the low molecular weight heparin right away. But in case of a non-ST elevated MI, you do have plenty of time in your hand. You have the time frame like maybe 24 hours, you have the time frame of 96 hours, or maybe like even 1 week back, like one week after. In our country, this is actually widely practiced in both the ST elevated MI and the non-ST elevated MI. We do not really, unless very severe, we do not really go for the like coronary intervention right away, because most of the patient actually present to us maybe 1 or 2 days later. And in that case, we don't really go for the coronary intervention, even if it is ST elevated MI. We plan for this to take place after the acute event has settled down a bit. And we go for like, okay, I'll give you the next, within the 7 days, we'll go for the coronary angiogram and the stent insertion. So in that case, they give you, like between the time coverage, they start off with the low molecular weight heparin. That's the rationality behind the, using enoxaparin or other unfractionated heparin. Okay, is that clear, Dr. Kamal?
Yes, ma'am.
Okay, all right. So as I was saying, long molecular weight heparin, you should consider some other anticoagulation. In the NHS, they prefer fondaparinux. Fondaparinux is, I think it's a antithrombin medication, antithrombin effect. And fondaparinux is considered if you're going for the PCI in the next 24 hours. And if you're considering PCI in the next 96 hours, then they usually go for maybe like glycoprotein 2B or 3A receptor, I think. Yeah, in the NHS, glycoprotein 2B or 3A receptors are widely popular. Like tirofiban or efzimumab, these medications. All right. So as I was saying, in case of an ST elevated MI, what's the role of thrombolytics then? Back in the days when we did not have PCI strategies, it's not like we're gonna just let the patient die, right? So we have to do something. So that's when the, like thrombolytics, the revolutionary idea of thrombolytics took place. And actually it was proven to save lives. It was a life-saving intervention done to the patient. So thrombolytis is suitable for the ST elevated MI within 2 hours, maybe in the district hospital, or in our country, we have that in the Upazila Health Complex as well. Even the Upazila Health Complex being a primary center, okay, we do have that access to the streptokinase. So in the district hospital, when there is no PCI available. So these are actually the indication for thrombolytics. So what thrombolytics are usually used? I will try to write like tissue plasminogen activator is superior than tenecteplase. And this is superior than alteplase. And alteplase is superior than the streptokinase. All right. So what are the absolute contraindication? Absolute contraindication. Okay, Dr. Neha, can you tell me one of the absolute contraindication for thrombolytics? In which condition we are not going to give the patient thrombolytic? Can you give me one?
Am I audible, ma'am?
Yes, you're audible.
Ma'am, could you please repeat the question?
Okay, so what there are several contraindications, right, for the consideration of thrombolytics, right? So
Yeah,
can you
yeah.
name me like one contraindication?
Hemorrhage.
Hemorrhage, okay, excellent, very good. Any acute or active bleeding, you should not go for the thrombolytics, okay. So Dr. I'm sorry for Dr. Obijit. Okay, can you tell me another contraindication?
So you can, coagulation disorder or pregnancy.
Bleeding disorder, coagulation disorder, pregnancy. Excellent. Okay, Dr. Deep.
Ischemic hemorrhage, then hypertension.
You mean ischemic stroke or hemorrhagic stroke, right? Okay, and uncontrolled
Yes.
hypertension. Okay. Okay, very good. Dr. Kamal, can you hear me?
Yes, ma'am.
Okay, can you tell me, we have discussed about some of the absolute contraindication. Among this, Dr. Riva said that bleeding, any acute bleeding, and Dr. Obijit has mentioned pregnancy, which I think is very important. And Dr. Deep has mentioned.
Yes, ma'am.
One
of bleeding peptic ulcer disease.
Bleeding peptic ulcer disease. Okay, that's very good. And Dr. Onupam Biswas, can you tell me one contraindication?
Aortic dissection.
Aortic dissection. Okay, very good. Any other contraindication rings your mind?
Stroke.
Stroke. Okay, this has been discussed.
Within 3 months.
Any head trauma? Head trauma. That is very important. Okay. All right. So I think everybody
And
knows about
nephrotoxicity, ma'am.
nephrotoxicity. Okay. This can be, but I think it's a relative contraindication, not an absolute contraindication.
Yeah, right.
Okay. All right. But pregnancy is an absolute contraindication. All right. So what are the important side effects of the thrombolytics? Bleeding, of course, right? And hypotension. Okay. Any other complication that can be associated with streptokinase, particularly? It can cause allergic reaction because the antibodies can be formed against the streptokinase, okay, thereby causing severe allergic reaction. All right. All right. Primary coronary intervention, or the PCI. So we have already discussed about the time frame for each of the scenarios, like in ST elevated MI, in non-ST elevated MI. So what if a patient is having unstable angina? Should we go for coronary intervention? Should we go for coronary angiogram? What is your answer? What's the rationality?
We should directly go for PAMI.
Sorry?
We should directly go for PAMI.
In case of
angioplasty, emergency angioplasty, we should go ahead with.
For the unstable angina?
Yeah.
Okay. But unstable angina has, it does not have any pathological, like myocardial necrosis. Unstable angina means that there is ischemia, not the infarction, okay? So if you go for the biopsy and histopathology, you would not get myocardial necrosis like you would get in case of an MI. So in case of unstable angina, we are not going for any intervention. We are not going for any angiogram. We are not going for any, let's say, PCI or angioplasty. What we are aiming for is the maximum guideline directed medical intervention or medical therapy, okay? Pharmacological
antiplatelets.
Yes, antiplatelets and statins and beta blockers and ACE inhibitors. We have discussed about this, but that doesn't mean that you should not go for other tests. So what are the other tests? Okay, so important test apart from the coronary angiogram is that you can go for the functional test, functional assessment of the myocardial viability. So actually, before going for these type of, like tests, there is a very primary risk stratification score. So the higher the score is, you should opt for angiogram or invasive procedure. Like, for example, I'll give you a scenario. A 70-year-old male has presented with typical anginal chest pain. He has diabetes and hypertension for a long period of time. Of course, you're going for the coronary angiogram here, right? In order to diagnose whether he is having any, ischemic heart disease or not. But if it's a female patient, okay, and if she's only 35 and she has unstable angina, she does not have any hypertension or diabetes, would you go for the coronary angiogram right away? No, right? So you can do the other test. You can go for the functional assessment. By functional assessment, I mean you can go for the MPI or the myocardial perfusion scan imaging. You can go for the DSC or the double-time stress echocardiogram. And there is a first pass contrast MRI, first pass enhanced contrast MRI. And people who have minimal risk, I think it's maybe less than 20 to 30%. If they have very minimal risk factor, for example, younger patient, female patient, no risk factor, even then you're not supposed to go for the functional assessment. Rather than you can go for the CT angiogram, sorry, CT calcium scoring. Okay, all right. So if you're sure that in our country, we do it very, like commonly, we go for the angiogram, like just like any other procedure, like it's no big deal. But in the Western world, particularly, you have to consider the invasive procedure. Before doing that, you should consider the risk versus benefit ratio, okay? If it's not a typical angina chest pain, if the patient does not have any risk factor, if the patient is young to middle age, if the patient is not having any immediate poor outcome, then you're not going to go for any invasive procedure, okay? So the PCI that I was trying to discuss about is that mainly I think you guys require what are the different types of stents, like types of stents that are used. Nowadays, we use the drug-eluting stent. Previously, it was just a normal metallic stent. It's usually from the titanium. It is made up of the titanium. There are stents of different sizes. And this, which size is particularly required, it is done by the during the angiogram process. They measure the diameter of the coronary vessel, and then they see like up to which extent the coronary vessel has been blocked or occluded, and then they estimate the size of the stent according to that. Okay. And there is two complications. I think one is restenosis, and the other one is ISR. What is that abbreviation? Reinfarction, or is it? I think, okay, just let me check. Okay. Okay, yeah, here. We've discussed about thrombolysis, secondary prevention. I'll discuss about that a bit later on. Sometimes bookish knowledge can be very, like daunting. I was just having my flow, and then I remember like, no, I have to teach you guys something from the textbook as well. Okay. Microinfarction management. Can you tell me which page number this is, the primary coronary intervention? Okay, I've got it, okay. Two main complications, one is the stent thrombosis and the other one is the restenosis, okay? So stent thrombosis is due to platelet aggregation. It's a bit fewer incidents, so it occurs in 1 to 2% of the patients, and most commonly in the first month. So you should know about the prevalence, and you should know about when exactly the stent thrombosis can take place, and usually presents with acute MI. And restenosis is due to excessive tissue proliferation, and of course it is a more common complication, like it happens in 5 to 20% of the patients, and it takes a little longer time, okay, because of the tissue proliferation usually takes place in a longer period of time. So that's why it takes in the first 3 to 6 months maybe. And risk factor, you should know about that, like diabetes, renal impairment, and stents in the venous bypass graft instead of arterial bypass grafts. So, okay. The types of stent, I think we have discussed about the bare metal stent or the metallic stent or the drug-eluting stent. Paclitaxel is coated, which can inhibit the local tissue growth. Okay. While the restenosis rates are, so okay, they're saying that in the drug-eluting stents, this is restenosis. Right, okay. As the prevalence of the restenosis is quite higher and there is tissue proliferation, in order to prevent that, we are, like coating the stents with the paclitaxel or rapamycin so that it doesn't take place. However, it can actually increase the, like it can attract the other clots and thereby making prone to reinfarction or thrombosis event. So this is just the bare minimum, like what are the different types of the stents and what are the complications. like stenosis and thrombosis, and what are the important risk factors for, like restenosis, like diabetes, kidney impairment, and venous bypass graft. So these are the important gist. This is required for your examination purpose. And just remember, like, how before doing the coronary intervention, what are the things you should do? You should gain an informed written consent from the patient. You should clean or shave the, groin area. And then you should maximize the antiplatelet option. So some of the, doctors, they prefer using ticagrelol before doing the coronary intervention. Like they omit 1 dose of clopidogrel and they, substitute that with ticagrelol, aspirin and ticagrelol combination in the bolus dose format, and then maximize the other medication, as well as they, open up an IV channel. And if the patient is having diabetes, hypertension, then you should measure the vitals before doing the procedure, as well as you should measure the early morning blood sugar sample. And before doing this coronary angiogram, there are several tests. For example, you should screen of the patient whether he's having any hepatitis, like go for the HbS antigen test, go for the anti-HIV test, go for the anti-HCV test, okay? So the patient should be free of from this infection. And we go for a rapid antigen test for the COVID-19 before going for a coronary intervention. Okay, now let's talk about the secondary prevention or the CCU management. Is it becoming boring, today's lecture? Because I'm trying to, say it from a very practical perspective. And rather than sticking to the book, of course, you can go through the book when you're, went back to your home, and you can do this by yourself. But if you just follow my lecture, then it will be a bit easier to catch on to that information. Okay, so secondary prevention, when I was discussing about the pharmacological management, I actually covered these topics. But I would just like to emphasize that when you discharge a patient, okay, so make sure that you are writing the adequate dose of antiplatelets. So what is the maintenance dose of antiplatelets, Dr. Vijay?
75 milligrams.
Yes, exactly. So you should go for the dual antiplatelet strategy here as well. And you should continue the dual antiplatelet strategy for 12 months. Or 1 year, okay? And then you can maybe stick to 1 antiplatelet agent. All right, and that dose is 75 by 75. Number 2 most important drug is statins. This should be given before meal at night dose. And ideally after an acute coronary event, 40 milligram. Okay, next one is the beta blocker. Beta blocker, whichever you have prescribed the patient with in the initial phase, you should continue that in like maybe 2.5 milligram in terms of if you're going for bisoprolol, or like twice daily, 101. Okay, and the number 3 is number 4. Number 4 is the ACE inhibitor. A lot of physicians prefer it at like morning dose. Some physicians prefer it at night dose. Depends on the suitability of the patient as well. So, okay, maybe 1001 anti-ACE inhibitor. Number 5 is after angioplasty, there is actually no need for any GTN. Okay, so GTN is not really given for longer time, but some physicians do give this for a long period of time for the anginal pain coverage. Okay, so these are the most important medication. But after there is like plus minus of other medication that depends on the patient profile as well as the physician's choice. But do not miss out the antiplatelets, do not miss out the beta blocker, do not miss out the statins, and do not miss out on the ACE inhibitor. So these are the 4 most important medications that should be given for the secondary prevention. Okay. So far, any questions? I hope not, because I was just discussing about very preliminary topics. Okay, now an MRCP hot topic, and that is the DVLA, or the driving restriction. Driving restriction. So of course, we know that when a patient is having the acute coronary syndrome, you're not supposed to drive. So stop the driving immediately if you're having anginal chest symptom. Number two, if you have sustained an ACS and you haven't undergone any definitive intervention, no definitive intervention was done. Not done. In that case, but you're on the optimal pharmacological therapy. In that case, you're not supposed to drive for 4 weeks. Okay. But if you have undergone angioplasty or PCI, in that case, just 1 week of driving cessation is fine. Okay. Now in terms of CABG, which is a bit more invasive operation. So in that case, we're going to be taking a bit longer time. So that's 4 weeks. And if you have had pacemaker inserted for any sort of complete heart block, or maybe, like sick sinus syndrome, or maybe, symptomatic refractory bradycardia following an MI. So in that case, if you have been inserted pacemaker, is 1 week off. Okay, but in case of implantable cardioverter defibrillator or ICD, if a person has sustained a malignant arrhythmia, for example, VT, and then the ICD was done, then you should not drive for 6 months. But for example, you have been diagnosed with Brugada syndrome, you have been diagnosed with HOCM. In that case, the ICD should be, but it was done prophylactically. In that case, ICD in that case, driving should be stopped for 1 month. Okay, and there is, I think, another one which is not that important. That is aortic aneurysm. Aneurysm depends on the size. If this is more than or equal to 6.5 centimeter or above, in that case, you should notify the DVLA and stop drive. Most of the time, this is actually, like the driving license is revoked because their aneurysm might rupture any moment. Okay. And I think in terms of cardiac transplant or heart transplant, no need to inform the DVLA. No DVLA. For the high blood pressure, no need to mention the DVLA. But if person is having persistently raised high blood pressure in the form of more than or equal 180 by 110, in that case, DVLA will assess that person, whether he is fit for driving or not. Okay, that's all about the DVLA, all right? Just go through this. I think there is very small information in the book. Whatever I've just mentioned is written in the book. Just go through that. Okay. Now, I think anything that I have left from the coronary syndrome. There are several boxes, I think, in your lecture note stating the mechanism of action, which is also quite important. So go through them as well. Like in the examination, they can give you direct questions like how does a clopidogrel act, or how does a fondaparinux act? So, like mechanism of action is very important. And these are like very straight cut questions. There is no twisting here. So you should try to get the full marks here. Okay. So I still have 15 minutes till 5 p.m. So I think I'm going to, like ask you guys some question. Okay.
And, is there a need for cardiac catheterization and oxygen saturation level?
Sorry.
Cardiac catheterization and oxygen saturation level.
Yes, it's needed, and it's very easy. Okay, I'll discuss about this. Because most of the time, in case of the cardiac catheterization, we're very much worried about the pressure gradient. But you should be very smart and tactful regarding this. So you should look at the oxygen saturation level because it is easier to pick up and easier to answer. Okay, and I had actually one question related to the pulmonary stenosis, and I applied this knowledge, and then I was able to get the diagnosis that it was actually pulmonary stenosis. Okay, so they're actually easy. You should try to make your life a bit more easier. So don't focus on the hard things, okay? Focus on the easier things. All right, so far, do you guys have any question for me? Okay, in that case, I will ask you guys some questions. Cardiology lecture is quite long, you know. In my last lecture, I will actually discuss about a lot of topics, but those are, you know, like very small topics, but yet pretty much important for the examination. Okay, Dr. Obijit, can you tell me some important lifestyle advices you would like to give a person who has just had recent episode of MI? After the, you know, like you're writing a discharge paper to the patient, and as a physician, what are the advices you should give to the patient?
He or she is a smoker, then stop smoking.
Yes, very good.
And to avoid any kind of fatty food and taking that may elevate its cholesterol level.
So stop smoking, stop fatty food, and any other advices you would like to give? Dr. Deep, would you like to add something to that?
Yeah, take your medication religiously.
Yes,
Don't miss anything.
very good.
And it could be exercise advice, graduated.
You're thinking
Yeah.
about exercise, okay?
Yeah.
Or a cardiac friendly exercise.
Cardiac.
Okay, yes. Keeping the patient active is very important, okay? So cardiac friendly exercise, by that I mean that you should at least go for 30 minutes minimum of exercise. There are so many cardios, you know, like you can do, which are heart friendly, and it like you should avoid, of course, vigorous exercise or maybe a high intensity training program, which is very widely popular among the younger generation. In order, this is actually one of the fastest ways you can actually get rid of the body weight. So I actually tried this. This is a funny story. Back in my third year, yes. Back in my third year, that's when I started dating, and I was very much conscious regarding my body image. Okay, so I used to be a very chubby girl. So I was like maybe 65 kilos back in that time. So I wanted to like lose my body weight really fast, and I was able to go down as low as 48 kilos. So imagine like from 65 kilos to 48 kilos. And the only way that I was able to do that was by doing the, you know, like HIIT exercise. And I'll tell you what, like it actually works like magic. If you're, you know, like omitting rice from your diet, and if you're doing the HIIT exercise, you will definitely lose weight within like maybe 2 months. But this type of heavy exercise is definitely not recommended for any patient with MI. So, you know, like heart friendly exercise, for example, walking, you know, like in long steps, or sometimes, you know, like jogging, as well as doing the treadmill exercise. These are all pretty much important. So that should be done on like 3 to 4 days a week, not all day. Okay. Another one is salt restriction. Okay. Salt restriction is important. Smoking cessation, very important, like you have just mentioned. And then weight reduction. Okay. And another important thing is to have adequate sleep, like 8 to 10 hours a day. And then try to avoid like strenuous or anxiety filled job. If you're working in the finance department where you're continuously bargaining with clients, then you should try, you know, like job reallocation, because this is not good for your heart. If you're working in the emergency as an emergency medical officer and you have undergone this severe MI, then do consider switching into dermatology even. Like, do not go for the emergency medical officer doctor. And I'm not saying that dermatology is not stressful. It is stressful, but compared to the emergency or the casualty department, or maybe even the cardiology department, it has a bit of less patient overload. So you should consider job reallocation. That is also important. And another important is by fatty food, we often mention patients that you should take cod liver oil or salmon fish or something like that. Maybe those are, you know, like high in omega-3 fatty acid. But be careful, do not suggest these to the cardiac patients, okay? In cardiac patient, omega-3 fatty acid will actually cause more atherosclerotic plaque, okay? And another important thing, I think it's not really discussed in our background because sex is a very taboo word in our country. But in Western world, this is often, you know, like advised to the patient, like you should refrain from sex for 4 weeks or at least a month, okay? And if a person is taking sildenafil or a phosphodiesterase inhibitor, never co-prescribe GTN, okay? That will actually have major cardiovascular compromise. All right, so these are the general advices you should give a patient with MI. All right, so, okay, these are very like easy question. So don't be alarmed. I think Dr. Anupam Bishash is there. Dr. Kamal has left. Dr. Anupam Bishash, can you hear me?
Yes.
Okay, can you read out the 176 number question? So this is on the screen, right? On the screen, this is visible?
Okay, visible now.
Yes.
A 56 years old man with a past history of ischemic heart disease is admitted with central chest pain radiating to his left arm associated with nausea. On arrival in coronary care unit, he is noted to be in complete heart block with coronary artery affected. Right coronary artery affected.
Right coronary artery, yes, very good, because you're thinking this is what type of
Complete
MI?
heart block.
Yes, complete heart block. And which MI is taking place? Right coronary artery
Inferior
is
MI.
responsible. Inferior MI, yes, that's very good. Okay. Thank you for taking this case. All right, Dr. I think 100, 181. Okay. So Dr. Deep, can you read out the 181 number question for me?
72-year-old man for exertional chest pain and exercise tolerance test. He declines an angiogram and is discharged on a combination of 75 milligram aspirin once daily, simvastatin 40 milligram once daily, atenolol 50 milligram once daily, and a GTN spray as needed. Examination reveals a pulse of 72 beats per minute and a blood pressure of 130/80 millimeter of mercury. On review, he is still regularly using his GTN spray. What is the most appropriate next step in management? So the options are most appropriate next step in management. Nifedipine 30 milligram once daily, sodium nitrate 30 milligram twice daily, paracetamol 200 milligram once daily, adnicrombil 10 milligram once daily, and parapamil 80 milligram 3 times a day.
Okay, immediately what comes to your mind, like which options you can rule out? The patient is already having beta blocker.
Yeah, so calcium channel for parapamil is not.
Okay, verapamil is not really needed here, right? And also nifedipine is not really needed here much. All right. So you have the B, C, or D option. Okay. So before going for something newer anti-anginal medication like nicorandil, you know that you can either go for B or C option. So can you tell me which option is more suitable for this patient?
Pulse is 72.
So the pulse is good.
So pulse is good. I should try at least atenolol.
To the maximum dose, exactly. Very good thinking, because once the patient is already having a similar type of medication, try to increase the dose rather than adding another medication. That's how you think like a rational doctor. Okay, so the answer is C. That is increase the atenolol to 100 milligram once daily. All right, very good. Okay, Dr. Neha. Dr. Neha, are you there?
Yes, ma'am.
Okay, so can you read out the number 186 number question for me?
Sure, ma'am. A 52-year-old female with an acute presentation of chest pain undergoes an angiogram to look for coronary artery disease. During the procedure, she has a run of ventricular tachycardia, which self-resolves. The report of the angiogram revealed normal coronary arteries. All other cardiac investigations were normal. What is the most likely follow-up plan? Should I read
think
the
this
options
one's
as well?
actually tricky. Okay, yes. Did you read the question? Do you understand what the question wants you to answer?
Yes, 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 yes,
Okay.
yes. I just go read the options one.
Okay.
Option A is insert internal cardiac defibrillator. Option B, perform an exercise stress test. Option C, discharge from cardiology when medically fit. Option D, commence amiodaron. And fifth is repeat the angiogram. Uh,
Which option do you think goes out the window immediately?
repeat angiogram.
Okay, exactly, because she has experienced this complication during her angiogram. So number
Yeah,
E is out. Okay.
yeah.
And do you think one single run of ventricular tachycardia during a coronary procedure is clinically significant?
No,
Because her coronary arteries are completely normal. So no need to go
normal,
for
right?
the option B, okay?
Yeah,
And no need to go for any medication for this as well. So B, D,
yeah.
E, all are out.
I
So would
think
you
we
like
should be
to?
going with option C, discharge from cardiology when medically fit.
Exactly, very good, because that is actually indeed the answer. And one single run of ventricular tachycardia during a coronary angiogram, which is an invasive procedure, that is actually a normal finding, okay? So you should not go for any medication or any devices planned for that VT. Okay, very good. Dr. Obhijit, okay, the next question is for you. I will not give you this question because it is self-explanatory, you know, like within the thrombolysis category. So you'll know immediately which answer to go for. Okay, I'll ask you a secondary question. Okay, number 191.
58-year-old man with no past medical history of note is admitted to hospital with rushing central chest pain. ECG on arrival shows anterior elevation and is subsequently thrombolized with good resolution of symptoms and ECG changes. 4 weeks following the event, which combination of drugs should be taken? Statin, aspirin, and beta blockers.
Yes, exactly, because you don't really need to go for the other options anyway. So this is how, very good thinking. This is how you actually, you know, like don't waste your time. You can move on with another question. Okay, anyone that I have left, participants, Dr. Anupam, I have asked, Dr. Neha Singh. Okay, I've asked. Okay, I'll just like to like mention one thing about the streptokinase or the thrombolytics. Like after you have done the thrombolysis, repeat the ECG. Repeat ECG within 90 minutes. And you will be seeing premature ventricular contraction or any ventricular origin arrhythmia, but that should not be medically significant, okay? So if you're any ventricular arrhythmia. So if you're getting these changes in the ECG, that means that the thrombolysis was successful. Another thing to tell whether this has been successful or not is repeat the tropi level. How so? In the tropi level, what happens is, like, for example, the thrombolysis has dissolved the clot, like from a section within the blood vessel, okay? Now it will actually, before it disappears, it will be dislodged. The clot will be disintegrated into smaller pieces, all right? And before it goes out of the circulation or within the bloodstream completely, it will cause a transient rise because of these micro clots will cause another further rise of the tropi level. So if you're getting a small rise in the tropi level after 90 minutes, within the 90 minutes time frame of a thrombolysis, then you should consider that your thrombolytics has been successful in terms of disintegrating the blood clot. Okay. All right. Now we will move on to our next topic, which is heart failure, because it goes hand in hand with the ischemic heart disease. Okay, heart failure, previously it had so many categories, like What exactly do we know about heart failure? What does a heart failure mean? When the heart is not being able to pump the blood into the systemic circulation, that's known as the heart failure. And this is solely dependent on one factor, if I may say, that is the cardiac output. When the cardiac output is low, you will get heart failure. Okay, that's the very gist of the heart failure. All right, so previously it was known as the systolic versus diastolic heart failure, and right heart failure versus left heart failure, acute heart failure versus chronic heart failure, compensated, yes, versus decompensated. So many terminologies were there before, okay? But now, thanks to the recent guideline, AHA guideline, we have divided heart failure into 4 categories depending on the ejection fraction, okay? So number 1, okay, we'll take like a very small break for the azan. Okay. So I had to take a very small break for the azan, and now we are back. So I will discuss, as I was discussing about the heart failure, okay? So previously there were various categories for the heart failure, but nowadays there is only 4 categories. Number one is, okay, I will discuss in a separate slide. Number one is heart failure with reduced ejection fraction. Number 2, heart failure, moderately reduced ejection fraction. Number 3, heart failure with improved ejection fraction. And number 4 is heart failure with preserved ejection fraction. Okay, so all of this actually depends on the cutoff value for the ejection fraction. Like reduced ejection fraction, there is less than 40%. Okay, with moderately reduced, there is 41 to 49% ejection fraction. With improved, it was previously maybe 41 to 49%, but after the medication and everything, maybe like because it has a reversible condition, now the heart ejection fraction has increased to more than 50%. So this is known as heart failure with improved ejection fraction. And heart failure with preserved ejection fraction is, there are signs, symptoms of heart failure, like patient is having shortness of the breath, okay? But if you do an echocardiography and you see that the ejection fraction is more than 50%, that is known as the heart failure with preserved ejection fraction. Previously, it was known as the diastolic heart failure. Something is happening, I think. আচ্ছা অটো ইয়ে হয়ে যাচ্ছে, স্ক্রিন চেঞ্জ হয়ে যাচ্ছে, মানে শেয়ার করিনি এখনো। ওকে, ঠিক আছে। আচ্ছা, থ্যাংক ইউ। Okay. So I know this is not really mentioned in the book here, but I think for the purpose of learning, you should know about this. Like, this is the modern classification of heart failure, and this is very important in real life patient oriented, heart failure estimation. All right, and another classification is the NYHA, which primarily focuses on the symptoms, like, for example, NYHA grade 1, 2, 3, and 4. So in case of 1, the patient is having no symptoms or minimal symptom, and patient is able to do the normal physical activities without catching up of breath. Number 2 is patient is having minimal sign symptoms and doing ordinary activities. They do not have any problem, but however, maybe 70% of the ordinary activity they can do at ease. The rest of the 25% they're not able to do at ease. Number 3 and 4, these are clinically significant. Number 3 is basically less than ordinary activity, patient is catching up on breath. And number 4 is even at rest, the patient is being breathlessness or patient is having difficulty. Okay, so that's number 4. So that's the NYHA or the New York Heart Association classification. And okay, I think for the part 1, that's all you need to know. Okay, next up is heart failure. What are the on examination finding? So as I was previously stated, that in the right heart failure, you get features of systemic congestion in the form of raised JVP, and you might get like peripheral edema. So edema is the term, like sacral or the pedal edema, ascites, and tender hepatomegaly. Okay, and in case of left heart failure, you will get pulmonary congestion in the form of shortness of breath, gallop rhythm, which is basically, gallop rhythm is the loud heart sound, okay? And number 3 is important, that is the bivasal crackles. So by combination of right heart failure, left heart failure is known as the congestive cardiac failure or the CCM, okay? And on what are the investigations you should do for a heart failure patient. Heart failure patient, important investigation, apart from all the other basic investigation and tropa ECG, maybe cardiac markers, blah, blah, blah. Important biomarker for the heart failure is the proBNP or the NT-proBNP. Now, in our basic clinical science class, we have discussed about the factors of ANP and BNP. Giving more importance to BNP here, I would like to say that the BNP basically is short for the brain type or brain-derived natriuretic peptide. So where does it release from? It is present in the blood vessel, in the heart myocardium, especially in the left ventricular myocardium, as well as in the brain. Okay, so when the heart is under any stress or strain, then the left ventricular myocardium will release this BNP in order to cause natriuresis. So that means that it will try to get rid of the excess volume buildup and excess salt buildup. So it will get rid of the sodium and as well as the water from the heart. So thereby causing less strain on the heart. So this level is actually raised in case of heart failure. Heart failure is definitely putting pressure or strain on the myocardium thereby. So what are the levels that are significantly high? So for BNP level and the NT-proBNP level, it varies a bit. So normal level is less than 100 picogram per ml, okay, for the BNP. For the NT-proBNP, it is less than 400. So if this is not raised, then this is not heart failure, okay? So it has a very higher negative predictive value, which I've mentioned in my previous class. So raised levels would be within 100 to 400, and high level would be more than 400. So both high or raised levels are significant for heart failure. Just like as NT-proBNP, so the raised level is 400 to 2000 picogram, and the high level is more than 2000 picogram. And apart from that, you should definitely check the kidney function, like the serum creatinine, serum urea electrolyte, all these levels are very important. And another important thing to see is on the CBC is the anemia. Because even after giving the patient right medication with the right doses, and even if the patient is compliant with the medication, still their increased hospitalization rate is observed in patients with anemia in the background of heart failure, because anemia is a provoking or aggravating factor. Okay, so all right. Prevalence maybe not that important, but just remember that heart failure, interestingly, female have higher heart failure rates compared to male. Might become shocking because we know that all the cardiac events are actually more common in the male compared to the female population, but heart failure is where the females are more affected. And the mortality and the morbidity burden is also higher in female compared to male. And 67% of hospital admission rate, as well as the mortality and morbidity, are associated with heart failure. Okay, and now in terms of treatment, there are some general approaches, and there are medical approach, and then there is intervention. So what do we mean by general approach? It all belongs to the cardiac rehabilitation. General, write down the word cardiac rehabilitation. So within the cardiac rehabilitation is smoking cessation, number 1. Number 2, correction of anemia. Number 3, exercise. Okay, you should encourage the patient doing optimal level of physical activity. All the general advices that I discussed previously for the MI patient, that should be applicable here as well. On top of that, I would just focus on the anemia correction. Very important. And number 2 is the vaccination. So vaccination is like influenza vaccine, and the other one is the pneumococcal vaccine, and nowadays COVID vaccine. So these vaccines are very important. If the patient does not have any other significant morbidity or mortality issues, like the patient does not have any kidney impairment, the patient does not have any splenectomized patient, so in that case, it's just fine if you go for one vaccine of pneumococcal vaccine, okay? But if the patient is asplenic or have features of hyposplenism, or patient is more prone to developing infection, has concurrent kidney impairment, in that case, you should go for the 5-yearly pneumococcal vaccine. Otherwise, just one vaccine is good. So these are all within the cardiac rehabilitation program. And then the other one is the pharmacological. This is the most important one for the part 1 examination, pharmacology for heart failure. So there is actually fantastic 4 drugs. Number 1 is ACE inhibitor or ARB, and nowadays ARNI, okay? Have you guys heard of the ARNI medication? What does ARNI mean? Okay, no problem. ARNI is actually a combination medication, okay? So ARNI is the combination for angiotensin receptor blocker and neprilysin inhibitor. Neprilysin inhibitor. Okay. So actually, if I'm able to pass this mighty PACES exam, and if I'm able to move to the NHS and work for the NHS in the UK later on, I do have plans to undertake a PhD project, and I would like to work on this particular heart failure, okay? Heart failure infection is going to be my broadly, like PhD topic. And I have looked up on different papers regarding the heart failure and the infection burden and everything. And nowadays, I think in NHS, they do not really go for the ACE inhibitor ARB. They just straight up go for the ARNI medication, okay? So ARNI medication, the ARB is given in 1 molecular weight, and the neprilysin inhibitor is 1:1. The combination is 1:1, okay? 1 molecular weight is to 1 molecular weight. And neprilysin inhibitor is basically, it inhibits the enzyme neprilysin. So why neprilysin enzyme is not needed in our body? Because neprilysin causes breakdown of the ANP and the BNP. We have already discussed that the ANP and the BNP, they have protective role in our body, okay? So if neprilysin enzyme, which is derived from the kidney, is broken down, then no longer it will be giving us protection. So in that case, we need something to stop that from happening, which is why the ARNI medication has been revolutionized. So that is done within the Fantastic Four. I think in our country, you can get 49/51 milligram combination. A lot of physicians start with the lowest dose, which is the 50 milligram. And a lot of physicians will go for like a higher medication, like 100 milligram. It depends on the patient status. Okay. Number 2, again, beta blocker. Beta blocker, like I previously mentioned, that it prevents cardiac remodeling, and it has mortality benefit. So giving a patient with heart failure beta blocker, you will be increasing his survival. So beta blocker is very important. Number 2, diuretics, and among the diuretics, spironolactone. Spironolactone, very, very, very important. This is a mineraloreceptor antagonist, and it has mortality benefit as well. Okay, and just remember, before prescribing spironolactone, you should not consider giving the spironolactone at night dose, because it will cause nocturia, okay? So try to give it like a morning or evening dose basis. However, in contrast to the spironolactone, the furosemide or loop diuretics, furosemide, they haven't been proven to any mortality improvement. So there is no mortality benefit. Clear? So furosemide or maybe thiazide, they do not have any added mortality benefit. That was number 3, okay. Number 4 is, okay, I've discussed about the diuretics, beta blocker, ACE inhibitor, spironolactone. Hydralazine and nitrate combination, I think. Hydralazine plus nitrate. But this should be given in patients who have background hypertension or MI. Most of the patients with heart failure, they usually have hypoperfusion, okay? Heart failure, on the background of heart failure, it's very rare to get hypertension. So hydralazine and nitrate combination should not be given to those patients. So another medication, especially if there is atrial fibrillation going on, then digoxin is proven to be helpful. However, digoxin has no mortality benefit. No mortality benefit. Okay. And another pharmacological therapy, for example, you're giving a patient with combination of ACE inhibitor, beta blocker, spironolactone, okay? At their highest dose, what the patient can tolerate or patient can, yes, tolerate. And now the patient is still symptomatic, or echocardiography evidence is showing that the ejection fraction is still less than 35%, or maybe less than 50%, whatever. So in that case, you can go for, before going for any intervention, you can give the patient ivabradine. However, before giving ivabradine, you should check the patient's pulse. Patient should be in sinus rhythm. Do an ECG. No, you cannot give ivabradine in atrial fibrillation. Number two, heart rate should be more than 70. I think in the book they have said 75, but 70 is according to the latest guideline. Okay, so pulse, heart rate, and the patient is having signs, symptoms refractory to the guideline directed medical therapy. And another indication is, yeah, I think that's all. Just remember that the patient should be in sinus rhythm, heart rate should be more than 70, patient still symptomatic regarding despite medical management, okay? In that case, you can go for the ivabradine. Ivabradine, I have mentioned that it acts as a funny channel inhibitor within the SA node. And one of the commonest side effects associated with ivabradine is luminal phenomenon. What does that mean? Luminal phenomenon is basically patient will be saying that, like, we know that in the commercials, they show us like an angel is coming from the heaven, and you see like the blurry, you see a light halo, which becomes blurry or distorted in front of our eyes. So this type of side effect can be associated with the ivabradine. And some people say that bradycardia can be another side effect, but however, ivabradine does not have much impact on the vessels. So I would say just remember the luminal phenomenon. That's the only side effect for the ivabradine. Okay, now we'll discuss about the coronary interventions. Sorry, not the coronary intervention. I mean the interventions done for heart failure. Interventions for heart failure. So long story short, if you just remember it, I will try to simplify it, okay? There are different devices for heart failure management. One is, number one, implantable cardiovascular defibrillator. Number two, cardiac resynchronization therapy. It can either be as a CRTD, which is like cardiac resynchronization therapy with a defibrillator, and cardiac resynchronization therapy with a pacemaker as well, CRTP, which is known as. And three, it's very uncommon in our country, which is known as the left ventricular assisting device, or the LVAD. It's basically you attach a pumping machine, which is straight given to the left ventricle, attached, and this machine is on the outside of the body. So that's why it requires a higher level of technological support. So this is not really practiced in our country. However, ICD and CRT, these are commonly done in our country. There are several indications, but I have tried to, make a gist of it, which is number one, patient is having NYHA grade 3 or 4 sign symptoms, despite the optimal medical management. Number two, do an ECG. And if the QRS duration is more than 150 millisecond. Number three, do an echo and the ejection fraction is less than 35%. And number four is the heart failure medication has been tried for more than 3 months, but the patient is still symptomatic. So these are the 4 indications for consideration of any intervention for the heart failure. Is that clear? From the online participants, I know you guys are not finding these topics in the lecture note, but this is for for the general knowledge, okay? So that you guys are prepared for any question related to heart failure. So what does an implantable cardioverter defibrillator do? the term defibrillator, we can know that it causes defibrillation. So for example, a heart failure patient, they might have more chances of having malignant arrhythmia, like ventricular tachycardia or ventricular fibrillation. In order to stop that from happening, ICD is given. That's a simple indication. CRT. So in heart failure patients, the heart will have areas of desynchrony. Like there will be some electrical abnormality within the heart wall. Some of the heart wall will be acting according to the normal physiology, and rest of the myocardium will not really act in such a way. So this is known as the desynchrony. The heart is not acting in a synchronized way. So in order to put the resynchronization back in, the device that is used is known as the cardiac resynchronization therapy. Okay. So that's just a very bare minimum of the medical interventions done for management of heart failure. Okay, so far any question for heart failure? So, okay, Dr. Deep, okay. So can you just tell me what medications show, like mortality benefit?
ACE inhibitors, spironolactone, beta blocker,
ACE inhibitor, spironolactone, beta blocker, and
ARNI,
yes. Another medication?
or hydrolysine.
Plus GTM combination, but only if there is a background of ischemic heart disease. Okay, very good. And recent guideline has shown that empagliflozin or dapagliflozin, which is known as the SGLT2 inhibitor, it should be given to heart failure patients irrespective of diabetes status, right? So, okay, I think this is quite rather not related to the part 1 examination, but I would just like to tell you guys that empagliflozin or dapagliflozin, this should be given 10 milligram, and it should be never more than 10 milligram in cardiac patients. And if the patient is having diabetes, then you can increase it up to 25 milligram, okay? The dose is not that important, just for the precautionary tale. And what is the most common side effect that is related to the SGLT2 inhibitor? Can anybody tell me? Urinary tract infection, right? Because it gets rid of the excess glucose through the, like urine or water work, thereby causing more urinary tract infection. Okay, very good. So far, I think I have covered all the points regarding the ischemic heart disease and the heart failure. Now we will discuss about the cardiomyopathy. Would you guys like me to discuss about the cardiomyopathy first, or the cardiac catheterization first? Catheterization, okay. All right, no problem. So I actually wanted to discuss this in the last portion, but no problem. Cardiac catheterization. So normally, what we know, I'll draw a diagram. This is the right atrium, right ventricle, left atrium, left ventricle. That's the aorta, very bad picture. That's the pulmonary. Okay, is the picture visible here? Like this is the diagram of right atrium, right ventricle. You see that the pulmonary trunk, aka the pulmonary artery, arises from there and divides it into 2 branches, goes to the 2 lungs. And then here you can see that the aorta is, ascending aorta is rising from the left ventricle, then the arch of aorta and the descending aorta, right? Very basic physiology. Now we know that in comparison to the right heart, left heart pressure is always high, okay? There is no debate regarding that. And we know that the deoxygenated blood in our body comes from the superior and the inferior vena cava, as well as from the coronary sinus that opens into the right atrium, right? So all the deoxygenated blood will come to the right atrium. From there, it will go to the right ventricle. And then from the right ventricle, the deoxygenated blood will go to the lungs for the oxygenation process. And we know that the oxygenated blood comes from the lung, open through the pulmonary vein into the left atrium. Okay, and then from the left atrium goes to the left ventricle. And then the left ventricle contracts the oxygenated blood through the aorta and then distributes this oxygenated blood in our systemic circulation. So we know that the pressure is high in the left heart compared to the right heart. That's true, right? And the oxygen saturation is more in the left heart compared to the right heart. So that's the very basic physiology, okay? Now, I will give some scenarios, okay? Just remember, like right atrium, right ventricle, pulmonary artery, left atrium, left ventricle, aorta. So normally, the level of oxygen is lower in the right heart. So this is roughly around 70% in the right atrium, in the right ventricle, in the pulmonary artery. And in the left side, this is 90 to 100%, so roughly 100%, okay? In the left atrium, left ventricle, and aorta, okay? There is no debate up to this level. All right, now what happens in the ASD, we know that there is some sort of like a gap in between the right atrium and the left atrium. And we know that the pressure is more in the left atrium. So from the left atrium, the blood will come to the right atrium. So you will get the more oxygenation in the right circulation, right? Okay, so the oxygenation level will actually increase in the right heart side in case of an ASD. So instead of 70%, it will be like 85% in the right atrium, 85% in the right ventricle, and 85% in the pulmonary artery. And in the left side, it will be normal, like 100, 100, and 100, okay? That's fine. And now in terms of VSD, the defect is within the interventricular septum. So because of the pressure, the blood will be coming from the left ventricle to the right ventricle, thereby causing more oxygenation in the right ventricle. But the blood is not going from the right ventricle to the right atrium, is it? No. However, from the right ventricle, it will be going towards the pulmonary tract. So the oxygen saturation in case of VSD, in the right atrium, that is 70%. In the right ventricle, this is 85%. In the pulmonary artery, this is 85%. And the rest are same. Do you agree with me? Okay. Unless there is reversal of the shunt, unless there is Eisenmenger syndrome, no deoxygenated blood is entering into the left heart. So the oxygenation level will be same in the left side. Is that clear? Because of the pressure. Because of the pressure effect, okay? Just because this is like, imagine, yeah, I mean, imagine like the oxygenation level is not dropping because the blood is flowing from the oxygenated area to the less oxygenated area. But when the less oxygenated area will go towards the oxygenated area, it will contaminate that area, okay? So unless there is reversal of the shunt or Eisenmenger syndrome, the left heart side oxygenation will not drop, okay? All right, so now comes the PDA. PDA means there is an abnormal connection between the aorta and the pulmonary trunk, right? And we know that the pressure is more in the aorta rather than the pulmonary trunk area. So what will happen is that the blood, oxygenated blood will enter into the pulmonary artery, okay? So, but there is no backflow happening, right? So in the right atrium, this will be 70%. In the left, in the right ventricle, this will be 70%. But in the pulmonary artery, it will be 85%, okay? And this will be 100%. Now, things will be a bit twisted when there is Eisenmenger, okay? In terms of Eisenmenger, you will see, I wanted to draw everything here, so I'm just gonna erase this portion. I think there is a better photo here. So far we have discussed about the ASD and the VSD and the PDA. You see that all this we have discussed so far. And now VSD with Eisenmenger, ASD with Eisenmenger, and PDA with Eisenmenger. Like I previously mentioned, like there is reversal of the shunt, okay? So in case of VSD with Eisenmenger, what will happen if you go back to our previous slide? So in case of VSD with Eisenmenger, there is shunt reversal. So the blood will be going from the deoxygenated area to the oxygenated area. So in that case, it does not mean that the equalization that was done or the bit of oxygenation that was done through the VSD previously, it will be gone now. So all this parameter, VSD with Eisenmenger, it will be 70. Here it will be 70. In the pulmonary artery, it will be 70. In the left atrium, this will be actually, in the left atrium, there is not much change. So it will be 100%. In the left ventricle, it will be 85%, okay? And from the left ventricle, since the aorta rises, it will be 85%, clear? Okay. And now you see, like with the ASD with Eisenmenger, similarly in the right heart side, the oxygenation level has not changed. However, in the right atrium, we know that, because of the reversal, the deoxygenated blood is entering into the left atrium. So it will be reduced. The oxygenation saturation will be reduced to 85%. From the left atrium, deoxygenated blood is entering into the left ventricle. So that is, all these parameters will be reduced because the problem is originating in the atrium. And PDA on the Eisenmenger, actually it will be, So in ASD plus Eisenmenger, the deoxygenated blood is going from the right to the left side. So in the right side, nothing will be changed. In the left side, this will become 85, left ventricle 85, and the aorta 85, right? VSD with Eisenmenger, nothing will be changed in the atrium. However, in the left ventricle and the aorta, it will be changed like 85%. And now patent ductus arteriosus with Eisenmenger, what will happen is the percentage in the right atrium, right ventricle, and pulmonary artery will be 70%. In the left atrium, it will be also 100%. In the left ventricle, it will be 100%. But in the aorta, the oxygen saturation will be low. So that is 100%, 100%, and 85%. Okay. So if you remember these particular parameters, then I think you'll be able to answer any question regarding the cardiac catheterization. From the online participants, have you understood me? Okay. Dr. Anupam Biswas, are you there? Hello?
Yes, I am hearing.
Okay, have you understood my concept behind the cardiac catheterization finding?
Yes, clear.
Okay, so without going through the book, can you tell me what's the finding in terms of patent ductus arteriosus?
Here only pulmonary artery, pulmonary trunk has changed, but all are normal, 70-70 and right side 100-100.
So you mean like in the right atrium 70, right ventricle 70, and then pulmonary artery is
85.
85,
85,
exactly.
and all other are 100.
All other 100. Okay, very good. I think
And
everybody has
also
got-
right atrium, right ventricle would be 70-70.
Sorry?
Right atrium and right ventricle will also be 70-70.
Yes, yes, exactly. Dr. Anupam has mentioned that. Okay. So I think everybody, all of you have gotten the how to interpret the cardiac catheterization finding. All right. So I will just go towards the myopathies. Okay. And that's actually our last topic of today. Okay. Cardiomyopathies. Okay. Number one, most common cardiomyopathy is the dilated cardiomyopathy or the DCM. Number two, there are actually 3 types of cardiomyopathy. A lot of books says it's 4 because they consider the arrhythmogenic right ventricular cardiomyopathy in a separate entity. However, I've tried to make it a very more simplified So DCM, or the dilated cardiomyopathy, is the top one because it is more prevalent. And the second one is the constrictive cardiomyopathy. And number three is, sorry, actually, all right. Number three is restrictive cardiomyopathy. Restrictive cardiomyopathy. Okay, maybe four. So that is obstructive. Previously, obstructive was actually considered a combination of dilated and constrictive cardiomyopathy, but now this is considered a separate entity. So for the MRCP part 1 purpose, obstructive variety is very, very important, very important. And I cannot stress you guys how much you guys will definitely get a question from the hypertrophic obstructive cardiomyopathy. This is like an open question. There will always be a question related to the HOCM. Okay, so now let's talk about the most prevalent question in terms of MRCP background. So obstructive cardiomyopathy, most common form is the HOCM, okay? Hypertrophic obstructive cardiomyopathy. This is, first of all, a genetic condition or familial. Number two, this is an autosomal dominant. All the cardiac structural abnormalities are actually autosomal dominant. Number three, the abnormal proteins are formed against the contractile proteins, okay? Like beta-myosin, alpha-myosin, or troponin T. So these myocardial contractile proteins against the abnormal contractile proteins are taking place because of the mutation. Okay, number four is, this is actually the most prevalent cardiac genetic abnormality. And the prevalence is 1:500. So this is actually pretty common, right? Okay. All right. So in terms of HOCM, what are the features? Well, on examination, important findings are pulse can be jerky. Number two, in the precordium, apical impulse is double apical impulse. Because what happens in the HOCM is that there is left ventricular outflow tract obstruction, okay? So because of that, the atrium will actually contract against a stiff ventricle. So thereby causing double, everything is double. Like in the pulse, there is two impulses. In the apical impulse, you'll get double apical impulse. And blood pressure can be normal to high. There is no that much variation. In the precordium, you will get an ejection systolic murmur, very much like that of an aortic stenosis murmur, which shows changes, which shows paradoxical rise in conditions where the volume of the left heart is reduced. So we know that in any left heart pathology, when the volume of the left heart is reduced, the murmur will also reduce along with that, okay? But in case of the outflow obstruction, there will be a paradoxical rise. For example, in case of Valsalva maneuver, we know that the cardiac output is ultimately reduced, right? So we are expecting that it should be reduced, just like any other left heart pathology, the murmur, like in aortic stenosis. If you go for the Valsalva maneuver, then the murmur actually reduces, okay? But in case of HOCM, the ejection systolic murmur will actually rise along with the Valsalva maneuver. Same as if a patient is standing, then HOCM murmur should reduce, but however, it will be increased. But in squatting position, this will be increased. So it sounds a bit complicated, but it's not that actually complicated. Just remember that conditions in which the left heart volume is reduced, HOCM murmur will be accentuated. All right. And important investigations are ECG and echocardiography. So in ECG, there is actually very non-specific changes. For example, you can get left ventricular hypertrophy, left axis deviation. You can get deep Q wave or symmetrical T wave inversion. Okay, but in terms of echocardiography, this finding is very important. So in terms of a positive family history, before going for the genetic analysis, the echocardiography is the main modality of investigation to see whether the other family members are affected or not, okay? Because genetic testings are very expensive. So something that can be, like picked up by a lesser expensive version, then you should opt for that. So echo is the means of detecting HOCM. So you can remember like Mr. Sam Ash. This is a mnemonic to remember. So MR, that it means mitral regurgitation. In the echocardiography, there is features of mitral regurgitation. Number 2, that is the systolic anterior motion of the anterior mitral leaflet. So if I draw a diagram, okay, this is like a mitral valve, the mitral annulus, and this is the anterior maybe leaflet, and that's the posterior leaflet, okay? So during the systole, the valves are opening, okay? During the systole contraction, the valve will open so that the blood can enter from the left atrium to the left ventricle, okay? So, but in case of the HOCM, the anterior mitral leaflet will actually deviate from the normal axis and it will move towards anteriorly. This is actually not possible to draw a 2D diagram, but just remember that SAM is basically the systolic anterior motion of the anterior leaflet of the mitral valve. Okay, number 3 is on the echocardiography, you will get asymmetrical septal hypertrophy. Septal hypertrophy. So these echocardiographic findings are quite important. And this is actually one of the most common cause of sudden cardiac death in young patients who have had maybe a positive family history. So remember the poor prognostic factors, poor prognosis. These are important, like younger age presentation, presented with syncope, positive family history of sudden cardiac death. And number 4 would be on the Holter monitor. Like if you go for the 24-hour or 48-hour Holter monitoring, then you will get non-sustained VT, which is a malignant arrhythmia. And also like ETT, sorry, on the ETT, if there is a paradoxical fall of blood pressure, more than 10 millimeter mercury. So that's the ETT poor prognostic feature, as well as a lot of people consider like septal hypertrophy, the measurement of septal hypertrophy can be a poor prognostic features as well. But that's also a thing of debate. Okay, so management, that's important. Management is, the optimum management is basically going for ICD, okay, in order to prevent any malignant arrhythmia. So ICD is very important. And the medical management is, you can go for the A, B, C, D approach, which is basically A is for amiodarone, B is for beta blocker, C is for calcium channel blocker, and D is for dual chamber pacemaker. And A, B, C, D, E, maybe E sounds like I, you can remember that like ICD, okay? So these are the management options, but never give, like I know that you are considering for calcium, in terms of calcium channel blocker, there is few debate, like there, you cannot prescribe verapamil in VT, right? We have discussed about that before. So unless if a patient with HOCM does not have VT yet, you can prescribe calcium channel blocker, that's fine. But if once a patient has had VT or presents with VT, then do not give verapamil. Unless otherwise, you can give the calcium channel blocker, preferably nifedipine or amlodipine. These are the medication choices. So, but the other medication is never to give is ACE inhibitor. And number 2 is nitrates. Never ever consider these medications. Okay. Now HOCM, from the HOCM, another important cardiomyopathy, which is genetic, is the ARVC. which is short for the arrhythmogenic right ventricular cardiomyopathy. So this is actually the second most common genetic cardiomyopathy. And presentation is a very similar manner, but the main pathology is within the right ventricle, where the myocardium is replaced by fibrofatty tissue. And in order to pick it up, instead of going for the traditional imaging, cardiac MRI will be actually confirming. So the confirmatory test is cardiac MRI. And treatment is pretty much the same, like ICD insertion. And among the antiarrhythmic, the sotalol is a medication of choice, which is a type of class 1 antiarrhythmic. Okay. Have I
Ma'am, what
discussed?
did you say at the last? ICD? Yes.
Sorry?
What did you say in the last after cardiac MRI?
Cardiac MRI, the management option. That is the definitive management is the intra ICD and implantable cardioverter defibrillator, and medical management is by sotalol. That's the drug of choice in case of ARVC, which is a class 1 antiarrhythmic agent.
Okay, ma'am.
Okay. Next topic is, have I discussed about the Brugada syndrome in previous class? No, right? Okay. So Brugada syndrome, as long as we're discussing about the genetic cardiac condition. So this is basically the SCN5A sodium channel. This is a sodium channel. When there is some genetic abnormality going on against this sodium channel particularly, it causes Brugada syndrome. In order to detect Brugada syndrome, ECG finding is quite important. This is more prevalent in the Asian rather than the, like European or the American population. ECGs, check the V1 to V3 lead particularly. And if you get like, I think this is ST elevation, followed by T wave inversion and right bundle branch block pathology, then that is very significant for Brugada syndrome. Okay. In the previous slide, I would just like to mention one thing, that is in the arrhythmogenic right ventricular cardiomyopathy, ECG finding, there is one particular ECG finding which is known as the epsilon wave. This is like P wave, the Q wave, normal QRS, but there will be a notching of the QRS complex, okay? This particular notching is known as the epsilon wave. HSM prognostic management I've discussed. I'll discuss about this a little later. Arrhythmogenic Brugada. Okay, let's see what they have discussed. More common in the Asians. Okay, that is also autosomal dominant fashion. Mutation, this is important. You might expect a question related to Brugada syndrome as well, because they might change the sodium for potassium channel, okay? Because the long QT syndrome, which channel abnormality is associated with that? Potassium channel, okay? But in case of the Brugada syndrome, this is the sodium channel abnormality. Okay, convex segment elevation, partial right bundle branch block, okay, fine. Treatment is implantable cardioverter defibrillator. Okay, and I will discuss about the DCM here now. So DCM, or the dilated cardiomyopathy, this is actually most common form of cardiomyopathy among all the cardiomyopathies that I have discussed. So the name itself suggests that all the heart will be enlarged, okay? The chambers will be dilated. And in the absence of congenital ischemic or valvular heart disease. And usually the left ventricle is more commonly affected by compared to the right ventricle. And there is more systolic heart failure compared to the diastolic heart failure. This is very theoretical, not in like reality anymore. Just we go for the LV IDT measurement in the cardiography and the left ventricular ejection fraction. So, and also we look if there is any hypokinetic wall in the echo. And we check the size of the chambers. Okay, so causes of DCM is very important. Most important causes post-viral, very important. Post-viral, alcoholic, in the Western population, most common. Postpartum, hypertension. These 4 causes you should never, ever, ever forget. And among the drug, doxorubicin. This is a chemotherapeutic medication. All the other causes you can remember, but do not, you can forget, like, but do not forget post-viral, alcoholic, postpartum, hypertension, and drug is doxorubicin.
Ma'am,
For
can you
the-
please go to that slide, the name of the drug?
Sorry,
The name
Hello?
of the drug. Hello.
yes.
The name of the drug you mentioned was?
Oh, I talked about doxorubicin. It's used in, like chemotherapeutic agent, particularly in breast cancer, doxorubicin medication. So it can cause a dilated cardiomyopathy or myocarditis. Okay. Now the restrictive cardiomyopathy. In the medical, in the residency program, they commonly give this question, like, what are the differences between the restrictive cardiomyopathy and the constrictive cardiomyopathy? For the part 1 examination, not that much needed. Just remember that constrictive cardiomyopathy, commonest causes tuberculosis, post-TB. And for the restrictive, some sort of infiltrative condition. Infiltrative condition, by that I mean maybe amyloidosis, maybe sarcoidosis, or hemochromatosis. These are the common causes for restrictive cardiomyopathy. If you go for an ECG, you will see calcification. Calcification is a prominent finding in the, chest X-ray. Chest X-ray, it's a prominent finding in the constrictive cardiomyopathy. But in case of a restrictive cardiomyopathy, the chest X-ray does not show that much abnormality. The heart is enlarged in restrictive cardiomyopathy. Heart will be enlarged. But cardiomegaly is not seen in constrictive cardiomyopathy. Rather, because of the constriction, the heart size might be reduced as well. So the heart is not enlarged. I think these are the important differences you should remember. Nothing much comes from here. Okay. And all right. I will just discuss disease of the pericardium. I'm sorry, because I'm taking up a little bit longer time, but this is important to discuss. 2 important topics that are particularly needed for MRCP part 1 is that pericarditis, and the other one is the cardiac tamponade. And pericarditis is actually inflammation of the pericardium, right? So it will be, the more prominent feature here will be chest pain. And this pain has a very characteristic feature, like the patient might experience this chest pain on lying down or taking deep inspiration, because the inflamed wall will come in close proximity with the chest wall, thereby triggering the pain. And if the patient is for the ease up, the patient might just, like sit forward. This is very much like the pancreatitis. So pericarditis, chest pain, this is important to remember. So what are the commonest cause for pericarditis? Whatever we have discussed in the myocarditis or the causes for the dilated cardiomyopathy, it will be the very much same, except pericarditis can be a part of the Dressler syndrome. So post-TMI is actually one of the commonest cause of pericarditis, okay? And there are other causes, like it could be post-viral, could be like traumatic, could be uremic pericarditis, could be autoimmune. So just go through the causes just for once, but remember the topmost cause is post-MI, okay? And treatment is, so the ECG change in case of pericarditis, you can expect like there is saddleback ST elevation. So normally in MI, we know that this is a convexity upwards. In case of a pericarditis, this is concavity. And also the PR segment will be depressed. Okay. PR segment is depressed, and management is basically treatment of the underlying cause, giving the patient adequate amount of rest, fluid, correction of electrolyte imbalance, as well as anti-inflammatory medication in the form of NSAID or steroids. These are the medication for the pericarditis. And cardiac tamponade is basically when the pericardium in between the visceral and the parietal layer, there is fluid accumulation to such an extent that it is a medical emergency, okay, cardiac tamponade. So there are several features for cardiac tamponade. For example, patient will complain of chest pain, shortness of breath, and patient, the JVP can be raised in cardiac tamponade. We have discussed about this previously. And another thing is that the pulse, you can get pulses paradoxes here. And Kussmaul sign is very debatable. I think it's better not to remember. However, Kussmaul sign is actually, this is basically when there is a rise in the JVP or with deep inspiration. So this is more characteristic finding of constrictive pericarditis rather than the cardiac tamponade. And important ECG finding is that you'll see beat to beat alteration of the QRS complex, which is known as the pulses alternance, right? In my experience, I have dealt with cardiac tamponade in the background of tuberculosis. Like this is actually a very, you'd be surprised, but it's actually quite common in tuberculosis, cardiac tamponade, pericardial or pleural effusion, okay? Pulses alternate is in the, you will look at the precordial leads like from V1 to V6, and you'll see like the electrical impulses are not that great. So generally the electrical impulse will be low. So there will be low voltage changes in the ECG, as well as maybe in one precordial lead, like maybe in V1, you get one type of amplitude of the QRS complex, and the next one you will get like another type of amplitude. So the amplitude is not same. So this is known as the cardiac tamponade. And let's see, important management is basically pericardiocentesis. Okay, so far, any questions for me? Okay, our last topic of discussion, I think, for today is the complications of MI, which that's why I was thinking like what I have missed, you know, complications of MI. This is actually one of the demerits of going with the free flow. You lose the track of, you know, like the topics according to the book. So complications of MI. Dr. Abu Taslim, I think, has joined us recently. So can you, okay, maybe that will be a bit random. Dr. Anupam Biswas, can you tell me one of the most common complication of MI?
Complete heart block.
Sorry?
Complete heart block.
Complete heart block, okay, that is very specific. Complete heart block is usually seen in inferior MI, that's fine. So we can consider cardiac arrhythmia, right? Broadly speaking, cardiac arrhythmia. Different types of cardiac arrhythmia can happen. Even in cardiac, before the cardiac arrest takes place, peri-arrest situation like VT, VF, atrial fibrillation, maybe a complete heart block, bradycardia, tachycardia, tachyarrhythmia, and cardiogenic shock is basically the same. Even SVT can also occur. Okay, so these are any type of cardiac arrhythmia can take place following an MI or during an MI. Okay, pericarditis. Okay, that's good. Pericarditis, it has a time frame. However, it does not take place before 48 hours. Okay, after 48 hours, it can take place. And pericarditis, and very close to that, another complication is Dressler syndrome. Dressler syndrome, it is actually a bit rare because it's autoimmune type of reaction. So when the myocardium is recovering, that's when, you know, like it will release a myocardial antigen property. And against that, your body will try to make antibodies. So this actually follows the autoimmune mechanism. And in Dressler syndrome, this takes place from 2 to 6 weeks post-MI. Patient might present with fever, pleuritis, pericarditis, pleuritic chest pain, pericardial or pleural effusion, all these features, okay? and the ESR will be raised. Treatment is mainly NSAIDs. Okay. Okay. Now another complication, Dr. Shubho. Sorry, Dr. Abhijit, can you tell me? Okay, septal defect, as in like VSD, very good. So you're talking about the mechanical complication, right? So the VSD, all right, that can happen. Number 4 is MR, which I have discussed in the very initial segment of our conversation. That is also a mechanical complication. And acute MR is always a surgical emergency. Number 5 is free ventricular wall rupture. Free ventricular wall rupture. So this is actually another devastating complication following an MI, and it can present in the form of cardiac tamponade because all the blood will be pooled in between the layer of the pericardium. So that's also a life-threatening complication. Number 6 is heart failure, like heart failure either in the form of acute or chronic heart failure. Okay, number 7 is any other complication? Left ventricular aneurysm. Ventricular aneurysm. This is very important because after an MI, if you see persistent elevation of the ST segment, so that might be very indicative of the left ventricular aneurysm. In that case, anticoagulation is very important because these patients have higher risk of stroke. And in between the mechanical complication like the VSD or the MR, there are other complications such as papillary wall muscle rupture, chordatin rupture, thereby causing the mitral regurgitation basically. So just remember the time frame, particularly the pericarditis, 48-hour, Bresler syndrome, 2 to 6 weeks. Do not mess these two things up. Okay.
Right
All right.
ventricular failure.
Sorry.
Right ventricular failure.
Right ventricular failure. Yes, I've discussed about this. And the heart failure. This can present acute and chronic heart failure. Okay. All right. So far, any of you have any questions from the discussed topic today? I will just recapitulate all the topics that I've discussed right in our third cardiology session. Number 1, we have discussed about ischemic heart disease. So from the presentation, different types, medical management, intervention, what are the complications that are associated with intervention, and DVLA, as well as the complications that can arise after an MI. So these are all the topics that are important in the ischemic heart disease. Number 2, heart failure. Most important topic for the part 1 examination is which medications have mortality benefit. Okay, this is the single most important question. And we have discussed about different types according to the ejection fraction. We have discussed about how to medically manage as well as consider different type of interventions. We have talked about ivabradine, and we have talked about what are the indications for using ivabradine. And number 3 is we have discussed about the cardiomyopathies. Especially important one is the HOCM. Never ever skip the HOCM part. And number 4 is we have discussed about disease of the pericardium, like pericarditis and pericardial tamponade. And number 5 is we have discussed about the cardiac catheterization. So if you guys have any question from all these 5 topics, please let me know. I hope you guys, all of you will be, go through at least once of these topics. If you are done with the topics from the lecture note, then you can also check some acute medical emergency management in the last few pages of the Oxford Handbook of Clinical Medicine. This book is very, I find it very important and very much in flow of the NHA's management, okay? Like in our country, the management style is a bit different, but in their country, it's a bit different. So in order to have that concise idea, and in order to pick up the difference, you can go through the last few pages of the, from the acute medicine portion in the Oxford Handbook of Clinical Medicine. Okay, so no more questions at this stage. So I will just, like stop my discussion. If you have still, if you feel like any difficulty understanding any topic, you can let it know on the Telegram channel. Okay, take care, everybody. Thank you.
Thank you, ma'am.
Bye.